Welcome everyone to Live with a Purpose. My name is Felicia Saraceno and I am the Director of Development here at the Arlington of Naples. We are excited today to welcome Dr. Ranasinghe from Integrated Pain Management of Naples. Dr. R, as she likes to be called, is going to be discussing today non-surgical options for back and knee pain, including some alternative treatments too. So without further ado, I'm going to turn it over to Dr. R. So welcome and thank you so much for attending today.
Well, thank you, Felicia. I appreciate that. Again, my name is Dr. Chaturani Ranasinghe. I am the Medical Director of Integrative Pain Management of Naples. I've been working as a pain management doctor for close to a decade after completing a fellowship at NYU. I moved here from the East Coast, where I was the director of the pain fellowship at the University of Miami, to start my practice here. I'd like to thank you for inviting me here to speak today about non-surgical options for knee and back pain. All right, I'm going to go ahead and switch to slide view. Okay, here we go. All right. So I've had to say, I've had such a nice warm welcome to Naples, where often people do ask me for that shorter version of my rather long Sri Lankan name. So Dr. R is perfect. So let's talk about knee pain. Knee pain is mostly caused by osteoarthritis and is the most commonly affected joint by this condition. Knee pain affects 30 million Americans, and this number is expected to increase as the population ages. Other than age, multiple risk factors have been linked to osteoarthritis, including occupational joint injury, anatomical factors, including joint shape and alignment, genetics, gender, and obesity. The two most common risk factors are age and obesity. So if you're over the age of 65, the probability of suffering from knee arthritis is 20 to 30%. Now, if you look at this chart with age on the X or horizontal axis and the incidence of knee arthritis on the Y or vertical axis, and add on the second most common risk factor, or excess weight, looking at it all together, the larger your BMI or weight per height, the more likely you are to have arthritis. And there is a dose response, meaning that the risk for developing arthritis increases by 15% for every point increase in BMI. But this is modifiable, and the good news is that every pound loss eliminates 4 to 6 pounds of pressure on the knees. One study showed that the probability of developing with a 10-pound weight loss over time arthritis, also called stage 1 and 2. This is usually when conservative treatments are started. Weight loss, as we discussed, and exercise are grouped under lifestyle recommendations and can help significantly. Physical therapy is great at all stages. Bracing helps when there are focal points of contact, but they're bulky and most people just don't wear them. Supplements and medications are trialed, and alternative treatments are also used at this time. In addition to these treatments, I also offer acupuncture for knee pain. Acupuncture appears to work by the reduction of inflammation by producing cortisol and pain-reducing chemicals such as endorphins and enkephalins. In terms of clinical trials, there's no strong evidence for this modality, but that is more likely related to design of the non-treatment or sham protocol, leading to conclusion in some studies that there was no perceived benefit. I believe it is worth trying as a low-risk, holistic approach. Exercise is beneficial even in end-stage arthritis. And in the long term, it increases joint or synovial fluid, which lubricates and nourishes the joint. Physical therapy is important to strengthen the leg, hip, and core muscles. So what about medications and supplements? Evidence supports trying glucosamine sulfate, which usually comes with chondroitin for its anti-inflammatory properties and cartilage protecting effects. The most commonly reported side effects are GI distress. It can also take weeks for effectiveness to fully manifest. This difference differs from NSAID or anti-inflammatory medications like diclofenac or ibuprofen, or like COX-2 inhibitors like Celebrex, where the relief is fairly immediate. But side effects are much more common, such as stomach bleeding and increased cardiac events. Therefore, a topical anti-inflammatory like Voltaren might be a good option to trial. In an effort to reduce or avoid stronger pain medicines, such as codeine and oxycodone, duloxetine or Cymbalta can be trialed, which has an FDA approval for the treatment of musculoskeletal pain. Off on glucosamine, we were talking about how it can take a few weeks for it to work, which differs from anti-inflammatories like diclofenac or ibuprofen. However, there are a lot of side effects like stomach bleeding and increased cardiac events. A topical anti-inflammatory can then be tried. In an effort to reduce or avoid stronger pain medicine like codeine or oxycodone, duloxetine or Cymbalta can be tried, which has approval for the treatment of musculoskeletal pain by the FDA. Common side effects are nausea, constipation, and dry mouth. Topical capsaicin contains an extract derived from hot chili peppers that changes the chemical makeup of sensory nerve endings and can also be helpful, and it's also over the counter. So let's take a moment to talk about how does arthritis develop. The theory that osteoarthritis is just a wear and tear degenerative process is being replaced with the idea that it is an inflammatory process initiated by tissue damage. Cells of the cartilage, the connective tissue that cushions the joint, called chondrocytes, start to change in terms of how they work and what they produce. Early on, there's swelling of the cartilage and there's disruption of the microscopic architecture. This is happening at a cellular level before any symptoms or evidence of breakdown of cartilage present. There's also a change in all joint tissues of the joint, not just the cartilage. The altered chondrocytes, or cells of the cartilage, start to produce degrading enzymes called proteases, such as metalloproteinases, and immune signaling proteins called cytokines. These cytokines are proteins that work like master switches to turn on immune responses. Now there is an imbalance of the inflammatory mediators weighted towards degradation. So again, this low level of inflammation is happening way before the cartilage breakdown as an early event. These enzymes further deteriorate the matrix of the cartilage, causing release of more enzymes and inflammatory mediators in a vicious cycle, causing loss of tissue architecture. The inflammatory substances also come into direct contact with nerve endings and cause pain. Over time, the loss of cartilage results in loss of joint space. Here we have a frontal view of a knee x-rays showing progressively worsened stages of knee osteoarthritis based on the Kellgren and Lawrence grading scale. In the circle, you have stage 3 and 4 arthritis, where there is reduced or markedly reduced space, leading to more frequent or constant pain. So this is evident on x-ray as loss of joint space. A lot of damage has already been done at this stage. And this is a common time when people are first diagnosed with the disease. MRI is a more sensitive modality for catching earlier disease. So why is it caught so late? Well, it's sort of a catch-22. First of all, cartilage is not highly innervated, so it's only when it's bone on bone do you feel it. The other piece of bad news is that the reduced vascular and nervous supply inherent to the joint makes it hard for the body to repair itself. As of today, there are no definitive curative treatments for arthritis, so goals are to treat symptoms and slow the degenerative process. For those who have not responded to medications, physical therapy, or weight loss, we will now trial injections of steroid or hyaluronic acid or lubricant injections, as well as so-called regenerative options. Particulate steroid formulations injected into the knee for those with moderate to severe arthritis looking for short-term pain relief where other treatments haven't worked can be tried now. There's also a new application called Zolretta, or extended release steroid, which lasts a little longer. These are useful to be used as a bridge, for example, to jumpstart weight loss or engage in physical therapy, or as a first line trial of injections. The reason we don't want to keep repeating these injections time after time is there's evidence it can lead to cartilage breakdown with repeated injections in the long term. What about hyaluronic acid injections? Hyaluronic acid is the major substance in the synovial fluid of the knee that works as a shock-absorbing lubricant. Over time, there is decreased and less viscous fluid. The intention of the injections is to replenish this fluid and increase production of more, allowing there to be protection of the cartilage. It's also thought to have anti-inflammatory properties and reduce the amount of those degradative enzymes we discussed. There are several different HA products available, and some are extracted from rusticomes. While it may take several weeks for the treatments to start showing results, the pain relief typically lasts 6 months, longer than most intra-articular steroid injections. Now, there has been some controversy in terms of its efficacy in literature, but it's possibly related to studies design overall. In a large study looking at claims database of about 180,000 patients, they found that after receiving the diagnosis of knee arthritis, just one injection delayed surgery on average by about 1.5 years. And this was extended to about 3.5 years if they had more courses of the drug. Those who did not have the injections had surgery within about 8 months after diagnosis. So these are compelling findings, and if anything, it allows us to potentially delay or for surgical planning. What about regenerative injections? I could easily devote all the remaining time talking about regenerative medicine, but to briefly discuss, there are injections of PRP, stem cell, and various placental tissues, which are more commonly available these days. PRP, or platelet-rich plasma injections, are most commonly used and are injection of separated concentrated platelets extracted from a person's own blood. A different category are mesenchymal stem cells found in bone marrow and fat, usually harvested from the hip and then injected into the joint. Another category is products composed of donated placental tissue from healthy cesarean deliveries, such as placental membranes, amniotic fluid, or umbilical cord blood, all thought to have high concentration of growth factors and cytokines. All three types of injections share the same goal: to augment the repair of damaged cartilage while reducing pain and inflammation. These are not likely to work for bone-on-bone arthritis and are more helpful in the early stages. And the caveat is there's no studies have actually proven it actually rebuilds tissue. Evidence is limited at this time, but these treatments do show the potential for pain relief and the risks are minimal. So for a lot of people, these non-surgical interventions for knee arthritis are inadequate. This chart shows the upward trend of total knee replacements from 2000 to 2010, with about 700,000 total knee replacements performed in 2014. With current predictions looking at a total of 1.3 million knee replacements by 2030. In fact, it's the most commonly performed surgery for people 45 and older in the United States. Surgical interventions for joint preservation are limited, but is often not an option for those who have many medical conditions or those who are too young or who are obese. So what options do we have that are between more conservative therapies and surgery? Until recently, there were none. That was until we had a better understanding of the sensory pain signals to the knee. The word genicular refers to the various arteries and nerves that feed into the knee. Anatomists and researchers found that there are small sensory nerves that give sensation to the knee capsule that could be targeted for pain relief. The picture on the right shows motor nerves that control leg movement and big vessels that supply the knee, which are behind the knee. The sensory nerves we're interested in are more in the front, therefore these important structures are avoided. So how does it work? The procedure itself is a two-step process. First, a test block or genicular nerve block is performed under fluoroscopic X-ray guidance that deposits a small amount of local anesthetic around these genicular nerves. If after the procedure there's at least 50% temporary pain relief, the patient is a good candidate for radiofrequency nerve ablation, where those same specific nerves are deadened. So what is radiofrequency ablation? Radiofrequency or RF ablation has many medical applications. For example, it is used in the treatment of varicose veins, to treat arrhythmias in the heart, and in cancer treatments, and is increasingly used for various painful conditions. In RF ablation, an electromagnetic field produced by radio waves causes high-frequency vibrations, resulting in frictional heat at the tip of the needle, allowing the interruption of sensory pain signals. It can provide lasting relief and is generally well tolerated with few associated complications. What is cool leaf ablation? One type of RF ablation is cool leaf or cooled radiofrequency. A key differentiator for cool leaf compared to other RF procedures is the use of water. Water is circulated through the cool leaf device while warming the nerves, so the actual needle tip remains at 60 degrees, creating a larger treatment area. That increases the opportunity to help the pain and creates a more spherical as opposed to oval-shaped lesion. This appears to be beneficial when it comes to encompassing the nerve as well as for the length of pain relief. Cool leaf is not surgery, therefore it's not invasive and requires no incision, and is designed to target only the sensory nerves directly responsible for causing a patient's knee pain. RF in general now has been used for hip and shoulder pain in addition to knee pain, so it's a great modality. Who should consider this procedure? It can be used in the management of moderate to severe knee pain after failure of other treatments. It can also be used in patients unable to have surgery or who want to avoid it. Despite good results achieved by joint replacement overall, up to 20% of patients continue to have problems with pain. These patients have very few therapeutic options at this point. Also, a nice feature is you aren't going inside the joint. The injections are outside the joint, which after a knee replacement, we generally want to avoid that. Who will it not work for? It's not recommended for those with an unstable knee or big issues with alignment, or if there's an infection or devices implanted around the knee. Genicular radiofrequency can be successfully performed for those with orthopedic hardware in place. What are the benefits? It can reduce pain, increase mobility, and improve quality of life. Another benefit of this procedure, it is not surgery. Therefore, it's not cutting and affecting the structure of the knee. As a minimally invasive option, it has few adverse events. Adverse events may involve transient discomfort and swelling or bruising at the site of treatment. But in my experience, this doesn't take very long. So not only is it a great option prior to surgery, it can be done if there's residual pain after surgery. It also has no effect on other treatments, like injections into the knee. For example, I've done this procedure before doing placental tissue injections into the knee. So in that way, we're reducing the pain, but also working towards potentially reparative treatments. I also work with one surgeon in town who sends me patients prior to doing their knee replacement for reduction of pain post-operatively, thereby enhancing their performance in the very crucial aspect of physical therapy after knee replacement. So there is a growing body of literature that endorses its use. In one study by Davis et al., they randomized 151 patients with chronic knee pain to either getting steroid injections or RF ablation treatment. At 6 months, 74% in the RF group had more than 50% pain reduction versus 16% in the steroid group. 22% in the RF versus 4% in the steroid injection group actually had no pain at 6 months. 26% versus 83% had no response at all, though. Although none of the radiofrequency patients had worse pain in 6 months, there were 15% of those who received steroid injections who had worse pain. In one study by Al-Hakim's group, they randomized patients to medications versus RFA, and they noticed reduced pain scores, higher satisfaction scores, and reduced stiffness at 3 and 6 months compared to a medication group. In Iannicone's retrospective study, they followed up patients at 3 and 6 months, and they found the average pain relief was 64 to 67% reduction of knee pain. 95% had pain relief at 6 months, also providing the response that they would recommend RFA to a family member or loved one, and no adverse events were noted. Caporal and his group did a long-term retrospective look at 183 patients, finding that 65% of the patients achieved more than 50% pain relief with an average time period of about 12 and a half months. Similar responses were found if it was a repeat procedure or if the patient had a prior knee replacement. And then a review and meta-analysis where they looked at 12 randomized controlled trials of a total of 841 patients was able to show reduced pain at 1 week, 1 month, and 3 months after RF with no reported adverse effects. Partial denervation has not been shown to mask acute injury such as ligament, meniscal tears, or fracture or instability. In short, it will not make you Iron Man. And the nerves eventually do regenerate, which takes anywhere from 12 to 24 months. In summary, RF ablation of the knee is a good conservative non-surgical option with a sound body of literature behind it for those who have failed other modalities. I've been doing this particular procedure since 2012 and find it to be a rewarding procedure to see the positive effect on people's quality of life. I've had patients become able to travel the world, play golf, or just do more at home, and it's been great to be part of that. I've also noted little in the way of adverse effects, and the worst case scenario being that it just doesn't work for a certain subset of patients. So very briefly, I'll discuss back pain in the context of some of the things we just discussed. But if you're interested, I'm happy to return and devote more time as it deserves really its own discussion. So if you obtain imaging of the lumbar spine using X-ray, CT, and MRI, after a certain point, it may show degeneration affecting multiple structures, such as herniated discs or spinal arthritis in different areas. Another term for this general degeneration is spondylosis. There can also be sacroiliac joint arthritis, which is lower in the back. So it can be challenging to isolate the cause of a patient's complaint of back pain. Degenerative lumbar spinal disease shares some common risk factors to developing osteoarthritis in the joints, including advanced age. A very common cause of low back pain is facet joint pain. Facet joints have been implicated as a source of pain in 15 to 45% of patients with chronic low back pain. Facet joints are connecting joints that come in pairs along the entire length of both sides of every vertebral or spinal level. They help keep the spine stabilized, provide posterior load bearing, and prevent excess motion. Facet joints are aligned with cartilage, so like many other joints throughout the body, can experience cartilage degeneration with joint space narrowing. They're also richly innervated, so they can be a potential source of low back pain. And that's just a sagittal view of a CT showing the arthritis. In a community-based study using CT imaging, the highest incidence of facet joint arthritis was found for those in the 6th decade of life, with 89% incidence, but not all those patients had low back pain. Therefore, the accepted method of treatment is to perform a medial branch block, similar to doing a geniculate test block of the knee like we discussed. If there is pain relief, then this is repeated. If there is significant temporary relief each time with 2 successive test blocks, this can confirm the source of the pain is coming from the facet joints in the back. The reason to perform 2 blocks is that there are high incidence of false positives if only 1 test and 1 level is performed. So as we had discussed, radiofrequency ablation that we have done for the knee can be done for the medial branches of the low back if a patient does not respond to conservative treatment for facet-mediated pain. This can provide relief for 6 to 12 months and for about 8 months in average. Because these peripheral nerves regenerate eventually, the procedure can be repeated when the patient's pain returns. So I want to thank Felicia for inviting me to give this talk to your community, and I'd like to open up the meeting for any questions.
Wonderful. Thank you so much for coming and bringing this informative topic for us. I'm sorry we lost connection on Facebook, but I think we'll be able to post this for everyone afterwards. And do you have any questions? I have a couple here.
I was just going to ask a question about, do these same therapies work for folks, say, with rheumatoid arthritis, with damage to the joints from, long-term effects of RA?
Yes, it can. That's the simple answer. Yes, it can be used, but obviously it's a completely different pathophysiology with rheumatoid arthritis. So the treatment of rheumatoid arthritis obviously needs to be underway, but yes, it can help pain from any cause of knee pain. So I've done this for patients with, for example, tibial plateau fractures, like where there's fractures around the knee. So it doesn't have to be from a degenerative process either.
Great, thank you.
No, you're so welcome. Good question.
And another question that I have that was written in is, do you have to block all the genicular nerves at the same time?
Yes, in general. Now, in some instances, I'll just do one or two, but in general, because the knee actually ends up having that innervation pretty consistently with either 3 or 4 nerves, I will generally block all of them at once, and then therefore, if they have a positive response, I'll do the ablation of all of them at once as well.
Okay, that's wonderful. And then how long does this last, and how often can this be completed for someone? How long can these injections happen?
Yeah, great question. The average is about, we're saying like 1 year or more. In my experience, it also depends on the severity of the disease. So I was doing this on the East Coast, and I would say it was over a year. But over here, I think there's more degeneration. I'm just in a slightly older population. So it's probably maybe 7 to 12 months. But overall, I see people coming back now and having this repeated, and they're doing quite well. So there is no cap on that. So they can have this repeated as often as they need. In fact, one of my patients just come back and he just sets himself up because he knows he needs to have it. And so he's just like, I'm just going to go ahead and book this now.
That's great. I hear from some folks that they say they can only get so many, say, cortisone shots a year, or it can only work so many times. How does this differ from that?
Exactly, because that's the point. That's the problem, is that with steroid injections, multiple applications now have been proven to overall degrade the cartilage even further. And so you're already, since we discussed the fact that the diagnosis of osteoarthritis usually comes at a later stage, we definitely don't want to accelerate the degeneration, thereby setting them up for eventual surgery. So this can be done, many times, because you're not influencing the structure of the knee. Now, what you are doing is reducing pain, and hopefully that's used in the context of, well, let me get involved with weight loss, let me get involved with working out more and strengthening those muscles, and also maybe lifestyle modifications and, things like that that can help to stay healthy. That's the goal.
That's important. How many patients do you feel, as a ratio, have more issues with and problems concerning their knees opposed to any other joints that they might have issues with?
Definitely, this is the highest. This is the one I see the most of. Yeah. And I think it's just because it takes a lot of weight. It's a weight-bearing joint. So it's very commonly affected. Yeah. In fact, I think most people, without knowing it, are already developing arthritis in their 40s. Unfortunately, they don't know about it until 10, 15 years later. So I think early diagnosis and maybe prevention is probably the key.
And for those prevention tips, what would you list as your top, say, 3?
Good point. Weight would be a big one. So maintaining a healthy weight, I think, is really important. Another thing is maybe prevention. If you can, to exercise in a way that is not doing so much high impact activity on the knees. Things like that. And then potentially taking supplements. Now, there's no hard and fast answers on those, but there's potential benefits taking things like glucosamine, chondroitin, and then curcumin as well, actually. And there's some newer studies that have shown that the active ingredient of turmeric, if taken every day, can potentially be helpful. In fact, they did the head-to-head with diclofenac and found that patients tolerated the curcumin more than diclofenac, which is understandable because often there's GI side effects with diclofenac. And then it also helped their pain. So if it could be taken early on, potentially could be helpful.
That's wonderful. So
Yeah.
some options for some folks for some non-weight bearing activities for exercise, what would you suggest? Swimming?
So yeah, swimming is great. Aquatherapy is terrific. Cycling perhaps, and then strengthening in terms of, weights are good to strengthen those muscles without being high impact aerobic activity, definitely.
Okay, that's wonderful. Do we have any more questions? I think we're okay for right now. So thank you so much for joining us today. This presentation has been so informative and I've learned so much, I know, and I'm sure our audience does as well. We will be recording this and uploading it to our YouTube channel. So if you want to review it again, because I know some of the slides were really important and informative. And you could also share with your loved one or a family or a friend who's going through this at this time too. Dr. R, if folks would like to get in touch with you, what's the best way?
So they can call my office. Let me see if I can share that with you. And that's some of the contact information. Here's the phone number and our website. And just give us a call. We'll be happy to talk to you.
Wonderful. And where are you located in Naples?
So we're off of Immokalee on Veterans Park Drive. We're close to the NCH North there, so by Goodlet and Immokalee.
Okay, that's wonderful.
All right. Well, thank you so much again, Felicia, for having me. It's been a pleasure, and I can't wait to meet you in person.
I know.
When all of this
non-virtually, and
yes.
It's a pleasure, and thank you again. And if anyone would like any information regarding the Arlington, you can always contact us at our phone number 239-307-3000. You can also find us on our website on www.arlingtonnaples.org or our Facebook pages, which is Arlington of Naples and Oakton Place, or our YouTube channels. And we can also do some virtual tours for you as well.